Assalamu alaikum and hello. I'm Dr. Lubna Naeem and today's moderator of the webinar, Understanding Race, Minorities and Health Disparities. We couldn't be more delighted and thankful to the president of APPNA, Dr. Naheem Usmani, and the chair and co-chair of Social Forum, Dr. Rao Kamranali and Dr. Atiya Khan, to allow us to host this webinar about important issues of healthcare disparities. 2020 has brought unrest, inequality, fear, division, and disaster. We have never been in a place like this before. Year 2020 met with large-scale COVID-19 disaster amongst the protests for racial justice. It has more than ever exposed the vulnerabilities of the society and the cracks in our healthcare system. The American healthcare system is troubled with inequalities that have a disproportionate impact on people of color and other marginalized groups. These inequalities contribute to health disparities, gaps in health insurance coverage, uneven access to services, and poorer health outcomes among certain populations. Physicians are intimately involved with institutions and system setups that contribute to the exclusion of Black people and other people of color. Where do we go from here? Addressing racism, discrimination, and health disparities in American medicine, and to learn how close it is to home, please join our esteemed panelists, Dr. Adil Heather, Dr. Jizar Ali, and Mayor Mary Moore. We want to appreciate Dr. Rao Kamran Ali, the Social Forum Chair and Co-Chair Dr. Atiya Khan for acknowledging and facilitating this important webinar. Dr. Ali, he is a leader of many talents. He is president of Ohio chapter and successfully leading PACPAC as the president. We would like to invite Dr. Rao Kamran Ali for his opening remarks. Dr. Ali.
Thank you so much, Dr. Lubna Naeem. You have done a great job and inviting great people. And thank you, Madam President. Assalamu alaikum, wonderful people. We are in really for a very special day. And I want to thank each of you for joining us on this long weekend. Martin Luther King once stated, "Injustice anywhere is a threat to justice everywhere." Understanding race, minorities, and healthcare disparities was always important, but somehow year 2020 has brought it on the surface. COVID is killing us, and we all can see that. But ironically, racial injustice has been killing people for centuries, and unfortunately, we have been insensitive enough not to acknowledge it. These disparities and injustice have not only affected but have exposed the flaws in our healthcare system as well, which our experts will further discuss. I believe we have to work together to fight such disparities and inequalities. I will end my remarks with another quote of Martin Luther King. "The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy." Thank you so much. I will invite back Dr. Lubnani.
Thank you, Dr. Ali. That was a wonderful opening remarks. Thank you. Joining us from Pakistan, please welcome our first panelist, Dr. Adil Heather. In addition to his role as Dean of the Medical School at Aga Khan University in Karachi, Pakistan, previously he was Director of the Center of Surgery and Public Health at Harvard and Brigham and Women's Hospital, where he still retains a faculty position. He's also the deputy editor of JAMA Surgery and holds numerous leadership positions. He has formally mentored more than 100 research trainees, published more than 350 peer-reviewed papers, and served as principal investigator on extramural grants worth more than $12 million. He is regarded as one of the foremost experts on healthcare inequities, with projects focused on describing and mitigating unequal outcomes based on gender, race, sexual orientation, ethnicity, age, and socioeconomic status. He is the recipient of numerous awards, including the 2017 Ellis Island Medal of Honor. We are very proud and honored to have him here as a panelist and as a wonderful role model. Welcome, Dr. Adil Heather. Our first question is going to be asked by our veteran leader, Dr. Atiya Khan. She has had many caps, many feathers in her cap, but at present, she is representing as co-chair of Social Forum, and I would like to invite Dr. Atiya Khan to come forward and ask her very first question to Dr. Adil Heather. Dr. Atiya Khan. Is she online?
So nice to meet you, Adil. It is a great pleasure and honor to see a Pakistani in that position. I'm very proud of you. So my question was about gender inequality in academia, as well as because I experienced it when I was at Georgetown, at Hopkins, and also about gender phobia otherwise for the other genders. Those are the two questions I had. And if anybody from the panel wants to take it, I would be happy to do that. And I can give you examples, but that was a long time ago because I am a veteran. As Lubna said, I'm an old person, but I've had experience of those two things, basically. So I wanted to ask you, how do you feel in Pakistan or in America, both places that you have been? Is there any gender inequality in academia, or I was the only one who experienced it?
Assalamu alaikum, and thank you again so much for having me. It is, of course, no surprise that President Naheed Usmani has chosen this kind of a difficult to talk about topic and has supported APPNA in focusing on something so sensitive. I also want to acknowledge and thank Rao Kamran Ali, who, of course, we all know from this forum, but of course from the PAC forum, which is doing incredible work. And I just want to say, right now I'm in Pakistan and I'm grateful for the opportunity to work at the Aga Khan University. But many of you know me, and of course I identify myself first as an American. And I'm wearing red, white, and blue tie today because I was speaking at APPNA, so I'm thrilled to be here speaking. And one of the ways America has progressed over the centuries is by talking about sensitive topics. And I want to tell you, sitting here in Pakistan, and because of the pandemic, I haven't been back in more than several months, which is very unusual. Sitting here watching what's going on in America is actually quite frightening. I mean, it must be the first time people here are more worried about people over there than the other way around, And what you're talking about, with social injustice, and I'm sure we're going to get more into those details in a little bit. But what you're talking about when you raise gender inequality, Dr. Atiya, I'm glad you bring it up, and I am sad to hear that you have personally had to, it sounds like, deal with it. Of course, there is gender inequality. There is gender inequality throughout the society in the United States, and of course, in Pakistan, it's a whole other ballgame. However, in the United States, as you know, women make 76 cents on the dollar, and that goes across academia. There are many women who do not get their fair pay compared to the men that they work with. And there are always all sorts of excuses. I remember a very good friend of mine who went to, her boss, who happened to be a woman, said to her, why do you need a raise? I mean, your husband's a surgeon as well. You together make a lot of money.
That's right.
Right? I mean, it sounds like you've suffered something similar. So this, of course, people need to be paid for the work they do. So there's absolute gender inequality. And the worst part is that some of it is just, embedded in society. Many of you must know about the recent Twitter and controversy called Med Bikini. Has anybody heard about this thing? Where it's from the Society of Vascular Surgery, and some potentially well-meaning folks decided to help people with their social media. And they wrote a paper talking about how surgeons sometimes put inappropriate posts on social media. Amongst the inappropriate posts were, putting up something in which you're, substantially intoxicated, or doing something which would be really frowned upon. But it also put up posts in which if you put up a picture while in swimwear. And this all male group, went and looked at the social media accounts of males and females and listed all these women who, put doctors who put pictures up of them on vacation, swimming, etc., and said that that's inappropriate. Now, of course, that's nowhere inappropriate because men can put anything they want and women can't put anything at all. That's completely unfair. I gave this as an example, not just to talk about clothing, but just to say how rampant it is in society that a journal literally published that. And of course, when folk got upset about it, the journal immediately retracted it. The apology, believe it or not, was written by the poor second-year medical student who was one of the second authors on this paper. I mean, can you believe that? That the apology was written by the medical student, not even the senior professors who were part of it. And then in response to that, JAMA Surgery, the journal I'm affiliated with, recently put out a call to change what we do and ensure that all editorial editors have diverse groups from gender and race to look at papers before they ever get published. And on that call, there are about 200 or so surgical journals, maybe 111 have already signed on. I give you that as just another example of how pervasive it is. It's there and how much money women make, it's how much tenure they get, how much articles get published, how much NIH funding they get published. And there are ways to make it better. Number one, we need to promote more women. And so, of course, we're grateful that the president of APPNA is a woman, but that's the first thing we need to do. Number two, we need to publish data on how these systemic issues are and then try to fix them. By number three, of course, creating policies, for example, this JAMA Surgery policy where they said that no paper would go out unless it is reviewed by a diverse group of editors. So I know that's a long answer, but you sort of picked something that I am very, very passionate about because I have so many women friends in surgery, and I just think they get a raw deal every day. And we should not be standing watching by. Men must be an ally with women to prevent this from happening. So sorry for the long answer, but I just think it's so important.
Thank you so much.
Thank you, Dr. Adil Heather. That was a great perspective, and we've been hearing about that recently quite a bit. Thank you for highlighting.
Sure.
Our next question will be asked by Dr. Mubashir Rana. He's the past president of APPNA and holds the position of Communication Committee Chair. Dr. Mubashir Rana.
Yeah. Assalamu alaikum. Can you hear me okay?
Yes.
Oh, okay. Assalamu alaikum, Adil. So it's kind of a related question. It's basically on healthcare disparities, which I know you've written and published. So as physicians, as you know, we always strive to provide the best care possible. But it seems like there's a conscious or subconscious bias, and there is healthcare disparity. So just wanted you to share your experience and suggestions on that. Thank you.
Sure, it would be my pleasure to do so. If I could just ask the host to enable me to share the screen. Somehow it says the host needs to enable me to do that. I actually, Dr. Mubashir, in response to your question, can share a couple of slides to focus on, all right, it's letting me do it now, so that's great, thank you. All right, so Dr. Rana, I'm gonna just take maybe 5 minutes to give you some data just to highlight what you're talking about. I wanna show this first paper, and this paper is from 1977. So many of you had not, were not practicing medicine at the time. I was about 3 years old. And this paper shows, it is from Johns Hopkins, and it shows that if you happen to be Black, and even if you have insurance, back in the day, the only kind of insurance you could have was Blue Cross Blue Shield, you were 4 times more likely to be operated on by a resident. This is back when residents do surgeries all alone. You were more likely to be operated on by a resident versus a fully qualified surgeon. if you happen to be Black, even if you happen to have insurance. And this was 20 years worth of data, and it focused primarily on open gallbladder. Of course, that's before laparoscopy, and hernia surgeries. So you can see the issue with healthcare disparities in the kind of care people get is, of course, very, very old. Now, fast forward many years, and you'll note that there are healthcare disparities everywhere. Everybody talks about them, right? There are disparities in outcomes after cancer. There's disparities in, for example, diabetes care. And you might think that, well, a lot of this has to do with access, right? That minority patients may not have the best insurance, may have government-sponsored insurance, or in a higher proportion probably, and that's why there are delays in care, and that's why they have worse outcomes. That's what everybody thinks as well. That must be the mechanism. But in trauma, that should never apply, right? In trauma, when people get injured, we take them right to the emergency department and we take care of them. But this is data that is now about 10, 15 years old, and this is one of the major papers that I was involved with. And what we showed in this paper was that even after a severe injury, the odds of death, if you happen to be Black compared to a white patient, was 20% increased. So a similarly injured Black patient was 20% more likely to die, even if they both had insurance, right? This is insured patients. And if you compared a white patient to an uninsured white patient, the uninsured patient had 50% increased odds of death. And then if you, added it up, so you took a uninsured minority patient, then that person had about an 80% or even a 210% increased odds of death. So this was, of course, something people were very surprised about, that why does this occur? And I will tell you that you were just mentioned about unconscious bias. I don't think that any of us go into medicine to treat people differently, but it is probably true that implicitly, we end up treating people differently. And these are a few papers in which we looked at different groups, medical students, residents, and nurses, and we found that amongst all the groups, turns out that we, doctors, have an unconscious preference towards whites, that we unconsciously prefer white people. And the big question remains that does this, and the data is skewed on this, some people think that it doesn't, and some people think that it does this impact how we treat patients? I do know that in my own case, I have looked at this carefully, and I think it probably does make a difference. Another major thing that we know that leads to systemic differences is, where patients get treated. This is some data on the difference in where minority patients get treated after severe injury. And this is how we usually look at trauma centers and their mortality. So if you plot all the trauma centers across America, level 1 trauma centers, these, where my cursor is right now, these ones are the ones that have a higher mortality. Trauma centers you really don't want to go to. And turns out that almost all the trauma centers that take care of high minority populations, they all fall over here. So what that means is that minority patients end up going to the trauma centers that have the worst outcomes. And that it helps explain, why minority patients end up doing worse. Now, since we are in this big pandemic, it looks like that the pandemic is certainly impacting folks of minority patients. And, before I get into more of that, I'll just stop right there. I have 1 or 2 more slides, but I'll stop and make sure I answered your question before I get into anything else.
Thank you, and Dr. Heather, for sharing your challenges and contributions as a doctor and as a scientist and as a team member. This was a very pertinent question. Thank you for answering that. Our next question will be asked by another community leader and an APPNA member, Dr. Salman Malik. He was the past president of APPNA New England chapter and past president of PAC as well. Dr. Salman Malik.
Assalamu alaikum. I guess everyone can hear me.
Yeah.
It's a pleasure to be here listening to all of this. Actually, one of the questions I had, in addition to what I'm going to be asking, is the disparity, the gender disparity that you see. I don't know if you can maybe touch upon what you see in Pakistan versus the US in relation to the fact that I see more female medical students, dental students in both nations. And has that made any difference? But that was just a side question. I wanted to see if there was if you had any thoughts on that, what the changes have been over the last 10, 15 years. With regards to the quality healthcare issue with the disparities that we see here, the inequality, the question I have is, how have issues such as physician burnout, high cost of healthcare, lack of funding for science is contributing to this healthcare disparity, and how it's getting bigger and bigger, in your thoughts? Thank you.
Well, I think if you focus on the main things that you brought up, the high cost of healthcare, right? So the first issue is that you can save people, but then you mess up their entire life. The proportion of patients, I mean, as you all may, of course, have heard, that the number one reason for bankruptcy, of course, in the United States, of course, is a medical debt. And so this is not a white or black or brown issue. This is a truly American issue that somehow the healthcare system has been so politicized that providing healthcare for all is a politically not the obvious thing to do. I mean, who could have imagined? I mean, just like Homeland Security is like a no-brainer, and preventing terrorist threats, and having a strong military, everything is, everybody agrees with this. There's not much debate. It just makes no sense that healthcare for all, that providing the basic idea of healthcare, is something that people have not been able to agree on. And so the high cost of healthcare, as the cost gets higher and higher, and the best procedures get so expensive that then Medicaid and other things don't cover them, and the more advanced procedures don't get covered, and especially therapeutics, clinical trials, these kinds of things get out of reach for patients who might be on government assistance insurance, or who might be on a kind of healthcare plan that they had to settle for just because of the high cost of healthcare plan. You can see how that further exacerbates and creates a more and more class divide within medicine. Regarding the physician burnout thing, I think you point at a very, very important thing. There has been work to increase the number of minority physicians and have a more gender diverse physician workforce. But the worst thing that happens to many of my colleagues who identify themselves as something different than white Caucasian is this thing called a minority tax. That whenever there's some minority issue going on, or something to do with minority related comments, they will always put these folks up. And many people get sick of it, right? And it leads, I think, it adds another stress that, oh, look, you're different. And I mean, many of you can relate to this, right? At APPNA, that if people ask you where you're from, and sometimes you feel like saying, sure, I'm from this part of the world. But sometimes you're like, why are you asking me? And how's that relevant? To single me out as somebody different. So that kind of stress adds to the stresses we have, and I think adds to physician burnout. Now, finally, and I know we want to get through this a little quicker, you asked about gender disparity in Pakistan. Well, look, it's a whole different culture and a whole different paradigm. Unfortunately, despite having more women in medical college, in most government medical colleges and other medical colleges as well, the number of women entering the workforce is nowhere near the number of women who graduate from medical school. I think this is pretty common knowledge. I can tell you what we do at AKU. When we bring women in, and of course, remember, it's the same people, right? It's the same culture, it's the same people. The difference is that the expectation is that on day one, you will be just like a male student. I remember when I was standing in line at Arman University, and I was standing in line, and somebody complained that, "Bhai, aurton ki line kyun nahi hai? Why is there not a line separate for women?" Which is a common thing. And the manager, who now is the vice provost at AKU, came out and she said, look, here the boys and the girls have to do exactly the same, so they're going to stand in the same line as well. And that expectation setting and that rigorous work that the men and women are doing, and I'm not saying in other medical colleges women get it easier, clearly they don't, but that expectation setting and that empowerment that when you graduate, a lot of people are investing in you, you must do something with this, and you have a social responsibility to give back. I think that is helpful. And of course, proportion of females who go back into medicine or who remain in medicine or some sort of career like that is way upwards than 90%. So there is a way to do it in Pakistan. It's the same culture. We just need to work harder at it. So I'll stop there. Thank you.
Thank you, Dr. Heather. Our next question will be asked by another community leader and past president of New Jersey and WAPNA, the women affiliate wing of APPNA, Dr. Rabia Awan. She also has many feathers in her cap, but I think I'm just going to go ahead and ask her to ask the next question to our panelist, Dr. Adil Heather. Dr. Awan.
Assalamu alaikum. First of all, I would like to thank Dr. Naheed Usmani and Lubna Naeem for arranging such a great webinar and such great speakers. It's an honor to hear all of them. And Dr. Heather, thank you so much for coming. My question is, how differently has the pandemic affected the people of color? And how differently we need to prepare for disaster management to ensure better access in future? What's your intake?
Sure. So I expected that to come up. So I'm going to go back to my screen share and give you just one slide, or maybe two on that. And so here we go. So I know many of you have, of course, read this in many places, that the pandemic has had a very disproportionate effect, that many more minority patients ended up dying from COVID than non-minority patients. Now, is that because of the difference in living conditions? It has to do with the increased inoculation with the virus? I mean, people are really trying to figure that out. Or is it that there are worse outcomes? We don't really know because we never track data good enough to really tell that, is it just within a hospital, for example, do minority patients do worse than white patients? I mean, we actually don't really track that data. And in fact, and you'll see a New York Times article there where I argue for the fact that, we should publish, or big hospitals or big hospital systems should publish their based on blinded and based on gender, to show that they are doing the same for everybody. I think that it is not known well enough that within hospitals do different types of patients do worse. One thing that we do know is that improving quality across the gamut does make a difference. And I'll also just give you these kind of 5 points, which were part of another talk that I was giving recently. I want to just make sure I get this in, that there are things that you and I can do today to ensure equality. The first is, patients come from all sorts of places, and we know as physicians, those of us who are in practice, know that if we are truly mindful and put ourselves in another person's shoes, we can understand why somebody's unable to follow the drug therapy regimen or even diet regimen that we might be prescribing, or the surgery we're suggesting. And if we give them a little bit more time and try to tailor their care in a more patient-centered way, we might be able to better impact their care. The next thing is this idea of cultural dexterity, where we train ourselves in managing patients in the kind of care in a way that they can personally understand it. Many times we feel like, this person is not from my culture, so I really can't get through to them. But if you develop skills, and there are 4 or 5 specific skills that we talk about in cultural dexterity that enable you to work with anybody in any cross-cultural scenario, it can make a difference. Third, of course, is improving quality, but monitoring your own quality. So we all get quality metrics, right? And you can always ask to see, for my own metrics, am I doing different for different people? And if we all did that ourselves, then we would know what's happening. We did a survey where we asked the surgeons, how their outcomes are, and they all said their outcome for a minority patient cannot be different. Well, then how's the whole system developing outcomes for minority patients? So clearly, if we only looked at our own patients, then it would make a difference. And then, of course, it takes leaders from within to hold your own systems accountable to ensure that they are making all patients receive the same kinds of care. So I hope that answers the question of, if we did those things now through the pandemic, will improve care for all. I also want to just make a point that, again, it's that APPNA is doing this discussion because it really is those of us who live in the United States too. It really is up to us to make a difference and kind of lead the way in how improvements can be made.
Thank you, Dr. Adil Heather. Thank you for joining and being our panelist. It was a great talk. Thank you very much for your input. We truly appreciate it. Thank you.
My pleasure. Thank you so much, Dr. Naeem, for having me.
You're very welcome. Thank you. Our next speaker is Dr. Juzar Ali, Professor of Medicine at LSU Health Science Center, New Orleans. He's an academic clinician, clinical educator, and a researcher in the section of pulmonary critical care, and has also worked in health administration throughout his tenure. His work is acclaimed nationally and internationally. He developed multiple programs contributing to the education of medical students, trainees, allied health professionals, and the community. He has participated in various multi-center studies and trials of tuberculosis and non-TB mycobacteria, and has co-authored a textbook, Pulmonary Pathophysiology. Dr. Ali is a recipient of numerous teaching awards at LSU Health Science Center over the last 2 decades, consistently recognized as a member of the Best Doctors in America, and is a full-time Fulbright Scholar Teaching Grant and Alumni Award, and Fulbright Senior Scholar Award twice, with academic tenures in Turkey and India. He has also been a visiting faculty to Vietnam under the US Vietnam Education Fund Program. Currently, his focus is on developing a mycobacterial disease mentoring and training program in the section at LSU. Thank you for your contribution towards medicine and welcome to the webinar. We will request Dr. Nadeem Qazi, our past president of APPNA, to ask the first question to Dr. Juzar Ali. Dr. Qazi. Is Dr. Qazi there?
All right, can you hear me now?
Yes, I can.
Hello?
Yes,
Okay.
I can.
Assalamu alaikum and good morning. Thank you, Dr. Naeem. Dr. Ali, this is 2020 they are talking about, then they talk about COVID. When those two things are added on, we talk about telemedicine. As CMS approved telemedicine, now people are using not only physicians, nurses, CRNAs, PAs, even counselors are using this technology. The problem, and then we talk about disparity, and what I see in previous slides that Dr. Heather showed, the trauma patient who was coming from poor socioeconomic area, they have a worse outcome, most likely because they may have secondary issues, diabetes, hypertension, obesity, whatnot. But in telemedicine, the socioeconomic issue brings another issue, that they don't have that technology available to them. With this changes, how you will teach us and your student or residents how to use this technology and what are the limitations of this technology in this day and age?
Thank you for that question, and thank you, Dr. Naeem, for that very kind introduction. I also had some thought as to what the questions may be. So may I have, if you can put in my slide It's one slide only, the last one. Because of time, I won't go through any other ones. Yes. And this one I created because of various thoughts that I had, and it will answer some of the things. Now, you may or may not see the script that much, but I'll walk you through it. And this is my perspective, and I will answer the question of telemedicine in a minute or two. What I look at as far as my experience in academic medicine is concerned, that when we are looking at a global picture of an individual patient disease problems, they are notwithstanding our journey from equality to equity to parity. That depends upon a lot of factors. And in that come some of these that are environmental or patient, some of these that are process related, some of these that are within the healthcare system, like within the box of the healthcare. And then only can we go through this journey from here to here and reach the parity. On the left side, my left side of the screen, or on this side of the screen, you will see some of the pointers that I have some of the points I've mentioned over here about the problems. But I would like to focus on this side of the screen very soon onto what exactly we need to be talking about today, and that is action. I know that awareness is there, the acknowledgement of the problems are there. We know, for example, in a study that came out of the American Indian population in the Colorado area, that one of the reasons their COVID mortality and morbidity was high was nothing to do with their health, but with the fact that they had poor transportation, problems of overcrowding, problems of language barrier, which made them have a bad mortality, bad outcome for their healthcare. We also know that access to care, fragmented care, where there are disconnected components of care, that is such an important part of how the mortality and morbidity and the parity of healthcare it cannot be achieved there. I'll give you an example of this particular part, where you may be able to access a doctor or you may not be able to access a doctor, but sometimes it's difficult to even access of a doctor, such as the office of a doctor. And that is very common that we see even in this country where we are supposed to have the best healthcare system. To give you an example, I can give a patient a prescription for oxygen, and he may get his oxygen but not get his oxygen tubing. Then there is a question of chronic disease management. In my opinion, coming from the academic part and inner city, it is not the incident care at the acute care level that is a problem. I think most of the people in this country can get access to to healthcare in an acute incident setting. What is the problem is the management of chronic diseases. And the chronic disease management, the fulcrum of that is dependent upon prevention. And the core of that prevention, in my opinion, is vaccination. And so these are the things that are really affecting the population. As far as COVID, since the COVID, in my opinion, is just the tip of the iceberg of the problem. Just because of COVID today, that we are talking a little bit more about this, and we seem to be aware and acknowledge this problem. But at the moment, what you need to realize, and we all do, that it's not just COVID related. This problem has been there for more than a decade. I was going through the literature, and when they're talking about these same things, equity, inequality, etc., in articles that were written in early 2000. So it's there. Now, we have found in New Orleans, for example, that we have 32% of our population are African Americans, and of them 76% had to be hospitalized. And that could have been probably due to many reasons other than their individual disease factors, other than their being severely ill, but it could have been also due to the fact that they have had poor access to care. Of course, we all know that more Black Americans have died in COVID. in my academic institution, we have found, as well as in other institutions, that there is a racial disproportionality to COVID-related trials. And that is something that needs to be looked into. We also know, irrespective of COVID, that there is an institutional aspect of some unconscious bias and what is termed in the literature as microaggression. And these microaggressions are essentially where there is an what we call as unconscious incompetence. And what we need to do is to convert that unconscious incompetence in our cultural assessment to unconscious competence, so that we are competent enough to address it even unconsciously. So with that in mind, I come to the solutions, and that is this side. And there I will answer this question about telemedicine. Telemedicine is, of course, one of the tools that we are using more and more now. But ladies and gentlemen, telemedicine is not something, is a new kid on the block. Telemedicine has been there. We've just not been using it as effectively as we should. In my institution, we have been using it for prisoner care, for remote care since 2010. And we are fairly aware of what the advantages and disadvantages are. So the advantages are access to care, agreed. The disadvantages are reduced cost of the patient to come to the clinic. The advantages are that, of course, there is probably more cost-effective care in the front end of it. But the two other things that need to be kept in mind is what is the patient experience of this care and what is the clinical experience of this care at the end of the day. And what I would like to really stress is that all telemedicine is not created equal. If you're talking about just telemedicine by doing a phone call and a FaceTime, then, you know, we doctors have been doing that for years. We don't get paid for it, unfortunately. Now suddenly we may. But calling patients on the phone and maybe sometime doing FaceTime with their permission is something that we are doing. However, what we really need to do for telemedicine and the limitations are, we need to understand the ethics of it. We need to understand the etiquette of it. And finally, we need to know what the limitations are. It's very good for, say, inspection and observation, but it may not be good for the actual examination until and unless it's escalated to use telemedicine examination tools. So if there is a diabetic who needs his or her examination of the retina every 6 months, and they don't come up to the clinic for that, and if we do telemedicine, but we don't do that, then it is not a problem that we have solved. So it is here to stay. We are probably going to get more robust about it, but it will need a more enhanced availability of tools such that it converts from just inspection and observation and just feel good talking to actual evaluation of a patient.
Thank you, Dr. Jazaril. Thank you so much for your input on this very important question. Our next question will be asked by Dr. Joseph Emmanuel. He is the past president of Jinnah Sindh Medical College, and he is pretty much adored unanimously by the entire APPNA community. He's our unanimous friend. Please welcome Dr. Joseph Emmanuel. Dr. Joseph Emmanuel.
Yeah, hi, thank you. Good morning.
Dr. Joseph.
Good morning.
Yes, thank you.
Yeah. Good morning, Dr. Ali. My question is how this disparity have impacted the academic medicine and healthcare during this COVID-19 pandemics?
Yes, sir. May I go back to the slide, sir, please? So it has impacted us in many ways. Of course, it has made us more aware. So there is a reason for us to kind of revisit this, look within ourselves again, and to see what we can do better. And in that, what I would say that the solution of that is the education of all the stakeholders. The education and the responsibilities that we all need to have at the academic level. And when I say at the academic level, it is from, as you now know, academics is a mixture of healthcare systems and physicians. In some cases, physicians are just vendors of care, pardon the phrase. But it's essentially we are providing services under a corporate healthcare system. So if that is so, then the education and the awareness of this disparity must come down from the top down C-suite to bottoms up and in between. And one of the things that we have been made more and more aware of, and we should be trying to do, is to change how we do things. For example, the new model of the mortality and morbidity conferences that happen in academics should now have considerations of these factors and not just disease factors. Once upon a time, we were talking about M&M conferences and we used to bring up the cost of care. Well, the cost of care is important, but so is the disparity of care that needs to be brought up in these conferences. Similarly, for example, in cases where there is a cultural bias or a racial bias, and this, by the way, is a two-way street. There may be a patient racial bias towards a physician, and there may be a physician racial bias towards a patient. Whatever it is, that needs to be brought up to the front. And that has to be done in almost the same model, in my humble opinion, as we do what we call as root cause analysis or sentinel event evaluation for Joint Commission. And that is used to be previously put under the rug and say, okay, oh yeah, he had a bad day today, or she's just an outside patient, etc. We used to tend to kind of dismiss these cases, sometimes even dismiss the patient because there was a problem. This is a difficult patient. Let's dismiss this from our system, etc. So easy to do. Well, the time has come now when this has to be brought into the forefront. So that has changed. And then thirdly, what we need to do is to establish more strong resource and research based. And that is what I think has the most impactful that has happened recently, where our research bases have now become more where we are more tuned to minority. One of the things that LSU has been in part in, and I'm sure other academics are, is this program that is NIH, which is called All of Us. This All of Us program is where minorities are asked to participate in this program so that we can develop more personalized, racial, personalized based research protocols for them. So those are some of the things that we're doing, sir.
Thank you. Thank you, Dr. Jazir. I will request Dr. Arif Muslim, veteran APPNA leader and past president, to ask the next question. Dr. Arif Muslim.
Assalamu alaikum. My question is for Dr. Jazir. We know that there is going to be an effective treatment and vaccine for the COVID-19, although not by election time as the president would like to have. But soon we would have a vaccine, inshallah, which will be effective and safe. So my question is, once it is developed, how will it be equitably distributed? And would there be any racial disparity in distribution and the availability of the vaccine once it is there?
What a beautiful question, Arif, but I'm a Humpty Dumpty. I don't know how it will be done, but I can tell you how it should be done. And that, of course, is very clear cut. We look at the data of the last 6 months, 9 months, and see who is it that is going to benefit the most out of it and would be the benefit from not only reducing their morbidity, but also their mortality. One of the things, RF1 and the group I would like to share with you is this, that our experience with vaccines, even in this country, is really not very stellar, sir. I mean, look at flu. The flu vaccine has been there since 1950s and of course gradually improved, etc. But the best numbers we have is like 58 to 64% people take the vaccine. So our first thing that we've got to do is to create trust. Trust with everybody that, okay, if this is the way to go, and of course, if you can't convince somebody who's not ready to be convinced, but if we create a trust about what the efficacy and the effectiveness of this is, then that would be the first step. The second step, in my opinion, would be to design a protocol of who would benefit most of it. The vaccine per se, and again, I go back to the flu, is about 50%, approximately. The 50 is a round number for everything in flu, 50% effective. So if 50 to 60% people take it, and if 50 to 60% are effective, it's effective for them, you can realize the skepticism there. So we have to go through that part. In other words, education, awareness, giving the right message, public service message, so that a patient, whether he is an African American or whether he is a white person, if he knows that he is at high risk, will come in asking for the vaccine rather than me running after a certain person to give the vaccine.
Thank you, Dr. Jazir, for your valuable time and joining us this webinar. And it was very valuable, very knowledgeable. Thank you so much. Thank you for joining.
Thank you.
Our next panelist, Mayor Mary Moore, the first elected African-American female to hold the position of Mayor of Pearsall, which is an underserved area. Being a healthcare provider, a physician assistant, she's an advocate of bridging the healthcare disparities of her city. A mother of two, a grandmother of two, well known in her community as the singing PA, and author of her upcoming autobiography, Still Standing. Her motto is, "If I haven't made a difference, I haven't done my job." Welcome, Mayor Mary Moore. I would like to invite Dr. Mohammed Naeem, the past president of South Central Texas chapter, to ask the first question. Dr. Naeem. Dr. Naeem, are you there?
So, Ms. Moore, in your experience, we are from this area. What have you seen? We worked in South Texas about the disparities in healthcare access to minorities and people of color, specifically from this area, from San Antonio to the Mexican border, to Del Rio. What is your observation in this? You're one of the healthcare providers as well. I will take your regional view on that. See? I hope they heard.
Ms. Moore, you're muted. Unmute, please.
Okay. Okay. I will start over. Thank you, Dr. Naeem and Madam President. Health disparities and challenges in Frio counties are great, Frio County. However, allow me to share a few statistics. Frio County is about 60 miles south of San Antonio, and the population is about 20,000. 79% Hispanic, 16% white, 0.5% African American, and 3.5% others. The median income is about $37,000, and 30% of the citizens in Frio County live in poverty. Our disparities in Frio County are great, and according to our data, the deaths are due to heart disease, cancer, unintentional injuries, chronic lower respiratory diseases, and stroke. Why is that? It's multifactorial. Geographic isolation. Frio County is located in a health professional shortage area. Currently, we have 5 physicians and 7 non-physician providers. Another reason, lower socioeconomic status, lack of resources, lack of adequate housing, jobs without benefits, underinsured, and the lack of insurance. The final reason is higher rate of health risk behavior such as alcohol abuse, drug abuse, tobacco use, unsafe sexual practices, unintended teenage pregnancies, risky driving, physical inactivities, and obesities. That is a summary of our health disparities within Frio County. Thank you.
Thank you, Ms. Moore, for your input on that question. I would like to now invite Dr. Nasser Qureshi, our past president of APPNA, to ask the next question. Dr. Nasser Qureshi. Dr. Nasser Qureshi, are you there?
I think he's not able to make it. I just got his text. Let's invite Syed Arman Raza because he has a question.
Dr. Arman Raza?
Like Sadiq, can you please unmute Dr. Arman Raza?
Hello?
Yes, Arman?
Yes, can you hear me?
Yes.
Okay. Now, I just had a question for Dr. Haider. Earlier, he did, show us a study from Johns Hopkins, I believe, where I think the poor patients were going to trauma centers with poor outcomes. I guess my question was, is it a function of the trauma center itself, or it's a broader question of the lower socioeconomic region where people are starting off with bad health and there's a selection bias there?
Thank you, Dr. Raza, for Arman, for your question. We will take your question to Dr. Adil Haider at the end of the talk. Our next question to Ms. Mary Moore is, Ms. Moore, as mayor of the city, please share the most compelling contributions and suggestions towards bridging the gap towards these disparities.
Thank you, Dr. Naeem. After I formed the grassroots organization to fight corruption in city government in 2014, I was elated when I was voted into office in May 2015. However, after about 3 months in office, the numerous ongoing issues made it impossible to address health disparities from a mayoral standpoint. Nonetheless, COVID-19 forced me into action, and I was determined to minimize the disparity of this virus. I began planning for the what if. Education on COVID-19 was disseminated via social media, the local newspaper, magazine articles, and as a result, we only had 4 cases of COVID-19 prior to the state opening up. Nevertheless, prior to the surge of the cases in Frio County, my colleague and I were assigned to spearhead the telehealth generated drive-through testing center for Frio Regional Hospital. Free testing was offered to everyone to include our seasonal and immigrant workers. Proactive measures began. Of the 400 patients tested, we identified approximately 10% with moderate symptoms who required medical intervention. Therefore, our COVID-19 regimen was implemented via telemedicine. And I'm glad to say we had a very successful outcome. The positive patient that was treated via telemedicine, 100% of them recovered without hospitalization or ER visit. And I credit this success to early intervention. Thank you.
Thank you, Mayor Mary Moore, for your input on this question. I would like to now invite Dr. Rizwan Naeem, the past treasurer of APPNA and president of SMC and former chair of Social Forum, to ask the next question. Dr. Rizwan Naeem.
First, thank you so much, Lubna, Rao, and Nahid for a wonderful seminar. This was the need of the time and very active participation. My question to Mayor Mary is just a little background. I think many of us work with international medical graduates. And when international medical graduates come to US, they have to either go back to their country or do a waiver, which is a 2-year basically working in an underserved area. And the disparity in health is very close to this question. What I'm trying to ask is the disparity in health. We know there is a disparity in rural versus urban healthcare. We know there is a disparity in underserved and overserved or well-served community in urban areas also. So many mayors, many governors have this privilege to make their regions as underserved area for healthcare issues. And if you do that, the jobs created in those areas can be used by international medical graduates. Again, 90% of the international medical graduates are minorities or other ethnic group. So then they become a very big source, and they are actually, Pakistani community doctors are serving in remote areas of all over the United States. What is the status in Texas? And can you do something to improve that issues of hiring international medical graduates for their waiver issues in Texas? Thank you.
Well, I can share basically about the areas of South Texas, but let me just highlight you on information about the impact of Pakistan American physicians' contributions to the community of South Texas. There are more than 12,000 licensed and practicing physicians who were graduated of the Pakistani Medical School. Approximately 25% of physicians across our country were trained overseas. Each year, Pakistan is one of the top 5 countries supplying its best medical minds to fill the gap and serve American patients in medically underserved areas. I personally have had the privilege to work with 2 of the best, Dr. Lubna Naeem and Dr. Muhammad Khan. Not only did they make a difference in my career, but they made a significant impact in bridging the gap in health disparities in South Texas. So as a result, I just really want to thank you for sharing this opportunity, and God bless you. Thank you.
Thank you, Ms. Moore. Thank you for your valuable time. And thank you for being on this webinar. Thank you so much. Before we go to the concluding remarks, I would like to ask the panelists to stay and to answer the participants' questions. Thank you. Now I would like to invite our president, the president of APPNA, Dr. Nahid Usmani, for the concluding remarks. We want to congratulate Dr. Usmani and her COVID-19 task force team, Dr. Aisha Zafar and Dr. Syed Chaudhry, for an outstanding work for our communities. I would particularly like to ask how the disparities in general and in reference to COVID-19 has impacted Pakistani American physicians, and what is APPNA's role in bridging the gap? Thank you. Dr. Usmani.
Thank you, Dr. Naeem. I think that APPNA physicians were on the front lines of taking care of COVID-19 patients, both here in US and Canada, but also physicians in Pakistan. And a lot of physicians suffered from the COVID-19 infections and fought very bravely. And, you know, as frontline physicians, our intensivists, our pulmonologists, our nephrologists, our infectious disease were on the cutting edge of science in New York, in Los Angeles, in Chicago, in Texas. You know, they are leading the COVID-19 programs for research, for therapy, be it plasma, be it remdesivir, and vaccine development. There is a lot of contribution by Pakistani American physicians where the COVID infections are concerned. And we are not even talking about all the philanthropic work that has gone on in APPNA. Thanks to APPNA's membership, more than $1 million were raised and were used for PPEs, food rations here in US and Canada and also in Pakistan. So coming to disparities, the searing and the sobering reality that is that in America, racism is a public health crisis. We see it deeply ingrained, impacting our nation's inequitable system of education, housing, criminal justice, governance, food availability, and healthcare. And today, we are just talking about healthcare disparities. Racial and economic disparities inhibit the ability of disadvantaged population to access healthy food, clean air, safe spaces, and career opportunities. Even well-intentioned allies can perpetuate unconscious biases and structural racism. Regretfully, our states, our cities, and even our medical community are not immune. We have to be sensitive, and it is not only our patients who suffer from such inherent biases and healthcare disparities, but it is also we physicians, particularly our female physicians and our colleagues and students from minority communities here and medical students and trainees, both in US, Canada, and in our country of origin, who have to work twice as hard and still face stereotyping, not get promotions, sidelined, not be presented with the same opportunities as our Caucasian colleagues. I think this is the reality, and this is what we are facing. And this is what we have to address, of work, bring attention of the policymakers to attend to. I'm very grateful to Dr. Lubna Naeem, who worked hard in putting this webinar together, our social forum committee leadership with Dr. Kamran Rao as chair and Dr. Atiya Khan as advisor. I'm very grateful to our panelists, my very good friend, Dr. Adil Haider, who joined us from Pakistan, Dr. Juzar Ali, one of our senior members of APPNA, who has a lifetime of achievements in academic medicine, and Miss Mary Moore, sharing her experiences and insights in healthcare disparities where she works and highlighting hidden biases. The question before us now is, we had this discussion, what is the next step? What are we going to do about it? As an organization, our shared values should inspire APPNA to be part of the change that is so urgently needed, to do our part to ensure a more just, equitable, and unified path forward for our people and our nations here in US, Canada, and in Pakistan. At APPNA, we embrace and celebrate the full richness of people, perspectives, and experiences. We want to create a community where all are and feel welcome and are able to thrive. As an immigrant community of physicians who are successful, our success is built on the foundation of the civil rights and struggles of the Black Americans, and we can never forget that. It was their activism for equal treatment that, among other changes, brought about the Immigration and Naturalization Act of 1965, also known as Hart-Celler Act. This law abolished earlier quota system based on national origin that had favored Europeans and established a new immigration policy based on reuniting immigrant families and attracting skilled labor to United States. We, as APPNA members, have been reaping the benefits of such change and now must redouble our efforts to pay back to the minority communities. APPNA physicians already work across the country in underserved area. Almost half of all APPNA physicians are in primary care. APPNA physicians have been on the front lines of taking care of COVID-19. APPNA chapters have been working to bring free healthcare to the underserved population by establishing free clinics, mobile clinics in disaster hit areas, free healthcare days to provide screening and vaccination. So we are very well aware of these challenges, but we can always do more and be more systematic about it. As individuals, no matter the color of our skin, the gender, we can help end racism by educating ourselves, by connecting with organizations that support our highest ideals, and reaching out to those who may be hurting or feeling disillusioned. We should encourage our students and trainees to dream big and pursue their passion, be it competitive specialties or careers in academic medicine, whatever their gender, whatever their race. Our next generation, brought up in US and Canada, is already well versed in these issues and often on the front lines of advocating for a more just society. We can learn from them, and join them in this pursuit. As APPNA leaders, we know we have a role too. We are committed to protecting and promoting the special function we play to provide a space, safe space for honest dialogue, universal truths, and common grounds. We should be committed to supporting our physicians and our communities in healing and in achieving change. That means engaging and getting involved, not running away because we want to be politically correct and in the right all the time. So that's my urge. We should reflect on what everyone talked about today and see how are we going to change our practice, how are we going to channel our activism for a more equitable and just society. Thank you so much, Lubna.
Thank you, Dr. Nahid Usmani. Thank you for your compelling concluding remarks. Before we take the questions, I would really like to thank all our panelists, Dr. Adil Heather, Dr. Jizar Ali, Mayor Mary Moore, President APPNA, Chair of the Social Forum, Dr. Rao Kamran Ali, Co-Chair Dr. Atiya Khan, our Q&A panelists, members and participants for taking time out of their busy schedule on the Labor Day weekend to participate in this time-sensitive discussion. We would like to go to our questions now. I think Adil, if you're still there, Dr. Adil Heather, if you're still there, Dr. Arman Raza, he had a question earlier for you. Would you mind taking that question? Thank you.
Sure, would be my pleasure. I think the question was related to the data that I discussed regarding outcomes for minority patients. You're right that it seems like all of these issues, for example, a pre-injury comorbid status would predict long-term outcomes or outcomes in general. But turns out that even when you adjust for that, so you have a similarly injured person of similar age, and everything similar except race, and the comorbidities are the same as well, you end up with worse outcomes. We also find that when people who get injured and they leave the hospital, long-term, minority patients end up with worse outcomes. Even though when they leave the hospital, they're maybe the same, long-term they have worse. So obviously that has a lot to do with access to care, a lot to do with a variety of many issues, including, probably how serious people take them and how people are invested in getting them taken care of. I'll give you one very quick example. I took care of a patient. She was badly injured. She happened to be from inner city Baltimore, maybe 12, 13 days in after taking care of her, she started to refuse all care. Now, this was perhaps one of the biggest saves of my career. She, went into cardiac arrest on the table, and, we were able to get her back, 40, 50 units of blood. And all of a sudden, she just was, tough to all the people who came into the room, didn't want to have her vitals taken, didn't want to have any blood drawn, et cetera, et cetera. So many people would say, oh, well, this is potentially people use the word like ungrateful, not happy. But the point was that this poor young girl was really suffering from PTSD or early form of PTSD because, she was a little kid who got shot, and no matter, it doesn't make a difference that she happened to be African-American, happened to be in a society or in a block where people were getting shot as kind of an endemic, terrible problem. For her, she was a kid, and nobody would give her the benefit of the doubt. Meanwhile, another young, similarly aged person, rich person, flipped their car and had some pretty bad road rash on her face, and there was like a line of psychiatrists out there trying to help her deal with her, oh my God, now how she's going to deal with her apparent issues to her facial trauma and so on. So I say this just to amplify how we end up, treating people a little bit differently just based on their circumstance in life. That has a lot to do with it. What you're specifically asking is, are there lots of things that explain away racial disparities? After controlling for everything pretty much, on balance, I will still say that scientifically we have, without a shadow of a doubt, shown that racial disparities, just the color of your skin, suggests that there's increased 20% increased mortality in many of the surgical fields. So I hope that answers your question.
Thank you. Thank you, Dr. Adil Heather. I have Dr. Bilal Hamid next. He would like to ask the next question. Dr. Hamid, are you online?
No, I think he texted me he had to leave. So we'll take the next question.
Okay, thank you. The next question is from Dr. Khalida Zaki. Her question is, please comment on disparities, including gender, among South Asian and Muslim immigrants, including refugee population. She's the professor of sociology. Dr. Jazar Ali, would you like to take that question?
Yes, I would. I don't think I am aware of any particular concrete data about that, but working in an environment where we see those populations, my experience comes from working in the field of immigrants coming over and with the field of tuberculosis. You may not realize, but TB still remains a big problem in the inner cities of United States. Not necessarily active TB, but latent TB and so on. So with that background, my answer to that is that there is a tremendous amount of awareness that has to be developed as to the needs of this population. There is a distinct data that suggests that healthcare is delayed in these populations because of various reasons, which do include the fear by these refugees and by those that are not yet documented that they don't seek healthcare and that they seek only incident-based healthcare. So to answer your question, there is definitely a need to be more aware of that in this particular population. And it brings me to again stress that what we need to do as physicians, whether we are in academics or whether we are in our own private practice, whether we are the gowns of the country or the towns of the country, but the gown has to go to the town. And the answer is that we've got to have more coordinated care where healthcare is connected from one point to the other. And the persons who are disenfranchised, disadvantaged for whatever reason, they fall through the cracks when these fragmented cares occur, and refugee population is one of them.
Thank you, Dr. Jazarali. I think this concludes our webinar discussion.
May I just, pardon me, but may I just clarify something which I saw on the chat comment to be sure that it is taken in proper context. My reason for bringing up the flu and the poor rates that we have in that is very apt, because in my opinion, this is how it will be compared to this flu-like illness. So whereas we have very good rates for other diseases that are taken for infections and for children immunization, this one will remain to be a challenge. Even in a healthcare facility where I was an administrator, believe it or not, the healthcare personnel took only 64% of them took flu shots. So that is an important thing. And the second point, which I'll just wrap it up quickly, and that is that although the guidelines for giving priority vaccinations are well outlined by either CDC or by other organizations, the ultimate will be dependent upon the states, how they develop it within their own public health system. But to give a short answer, yes, those who are at a higher risk, then the frontline workers and so on will be the ones that will probably be getting it. I just wanted to amplify and clarify that before we end. Thank you for that opportunity.
Thank you for the clarification. This concludes our webinar discussion. Thank you all. Be safe and enjoy the Labor Day weekend. Thank you for joining.
Thank you.
Thank you very much.